Hello, and welcome to this re-recorded webinar on Functional Neurological Disorder presented by Dr. Price, Consultant Neurologist. Before we begin, I'd like to take a moment to introduce Inneg. We are a specialist medico-legal consultancy dedicated to supporting our solicitor clients with accelerating your claim lifecycle and reducing unrecoverable costs. How do we do that, I hear you ask? In 3 ways. First of all, by connecting you with the right high caliber experts and managing this process from start to finish. Number 2, streamlining the process of preparing medical records and the subsequent pagination of them. And number 3, ensuring timely access to essential diagnostic and treatment services nationwide. And the best thing of all is how we work. We act as an extension of your team, providing you with a dedicated analyst assigned to your case, dealing with it from start to finish, tailoring our approach to how you work and your unique needs. But enough of us, back to the webinar. This webinar will provide a detailed exploration of FND, including its medico-legal implications. Be sure to stay tuned for the subsequent Q&A session at the end. The questions were live at the event and we have re-recorded it due to some issues on the first recording. Dr. Price addresses some insightful questions that could really direct some of your cases, and he is available. His details will be available should you have anything you want to reach out to him directly for or you want to instruct him on. Thank you for joining us. Let's dive right in.
Thank you, Leo, for a very kind invitation to talk to groups of medico-legal solicitors who are interested in the neurological aspects of what we do, and in particular what we call functional neurological disorders, or abbreviated to FND. I'll just say a little bit about me. My name's Christopher Price. I'm a consultant neurologist in Exeter, and I do medico-legal work through Leo's organisation. I am a general neurologist, I think, first and foremost, and I think that's important to emphasise because in our specialty it is important to have a wide-angle lens. I guess that is not to say that I know less and less about more and more, in contrast to the specialists who know more and more about less and less, and I guess there's a balance to be struck there. So just a little bit about the organisations I work for, based in Devon, I don't work for Devon Partnership or FND Friends, but they are certainly 2 organisations with whom we work quite closely with. Just to give you an overview of what we're going to talk about today, we're going to try and pin down what FND is. We're going to have an overview of how we approach the problem in terms of diagnosis, of some management strategies. We're going to come to the medico-legal aspects in the context of that, and I have a case to present to you which I hope will illustrate some of the important points, but also some of the challenges. Now, speaking of challenges, this is a common problem and often a challenging one. It's estimated somewhere in the region of 20 or 30% of outpatient neurology appointments within the NHS have a clear functional component. So this is something that we come across quite frequently. And it's important just to note that if you look at the subjective ratings of those patients who we see, actually their quality of life is not so good. And then I think the other point is to say is that this doesn't necessarily go away. Some patients get better, yes. Many, sadly, do not. There are a number of common myths with respect to functional neurological disorders, which I've tried to outline here. I won't read them out, but needless to say, these do crop up not infrequently in a highly pressurized NHS. So, for example, locally, we've been doing quite a bit of work with our ED staff, who I have to say are fantastic at picking up functional problems, but clearly not a particularly good environment to address someone with a functional neurological disorder when chaos and scary stuff, frankly, is all around you. There is often, and I don't necessarily restrict this to caring staff, a perception that these patients are trying to manipulate the situation, and undoubtedly some do, but they are a minority. There is a misunderstanding that most have suffered childhood abuse, but it is, of course, common and not necessarily restricted to childhood. MAD is a word I tend to avoid, and my psychiatric colleagues similarly. It's just not helpful. And over the years, it's become very apparent that this is neither the sole domain of mental health services nor neurology, and really that's really where we're trying to go with services for such patients in terms of bridging that gap. I thought a little historical context was helpful. If you wind the clock back several thousand years, there was certainly a supernatural element. I can't tell you whether it featured in any of the Greek mythological works, but I think a little bit further forward in history, certainly witchcraft played an important role in conveying, I suppose, functional neurological disorders. And I think it's worth bearing in mind that if you went back 200 or 300 years, that many people with epilepsy were deemed to be possessed. Coming a little bit more up to date now, we now are increasingly embracing behavioral and cognitive models, and perhaps an example of this might be the learnt type of phenomenon, learned helplessness in depression, just by way of an example, although not necessarily directly attributable. And of course, there remains much debate as to whether functional neurological disorders are present either at a conscious or a subconscious level. There are some helpful things to say and do. I'm going to just touch on the things that we try and do. We try and not be judgmental. These patients are often those who have very high resource use, and I'll come on to the role of a neurologist in trying to limit that. There are plentiful resources to try and give more information. We do talk about how the mind and the body live in the same place, and involving a number of specialties is usually the most constructive way forward, and I'll come back to that a little bit later on. Specifically, however, with respect to the role of neurology, first and foremost, we have a role in diagnosis. There often exists a lot of doubt in this scenario, and we have an important part to play to try and minimize that. I think it's fair to say that we cannot exclude it altogether, even in our own minds, but we do try and do that. There's a role in conjunction with colleagues from other specialties in terms of patient education, and indeed recently in Exeter we've instigated a pathway whereby hopefully patients can go on a 3-month course of online psychoeducation before moving on to slightly more specialist assessment and treatment if required. We often called upon to give guidance and advice. Hickham's dictum, for those of you that might be familiar with it, says that patients can have as many disorders as they damn well please, and indeed they can, and just because they have one does not mean that they can't have another. Although, of course, if you do have FND, it is a reasonable probability that future symptoms may in some way be related, but by no means guaranteed. we have a role for informing wider care, particularly within primary care, and I think increasingly they're becoming a bit more comfortable with the concept of a functional problem. I think coming with a little bit more support from secondary care. So I'm going to show you a brief video now. Some of you will be familiar with it. I hope it will make all of you smile. And I'm just going to ask you to have a little think about what you think is going on here. Do you think that this is a voluntary problem? Do you think it's an involuntary problem? And then I'll give you a clinical scenario with respect to that, having watched it. Here we go. I really hope it works. Anyway, I think you get the message. So just have a little think. If that gentleman came into your neurology clinic and said, I'm not in control of this. It's causing me quite a lot of distress indeed. You know, I'm a bit worried that on account of it, my job's on the line, my marriage is looking a little shaky, and in short, or in summary perhaps, yeah, my life is slowly, gently, but nonetheless, definitely crumbling. So I think it's important that we come on to the sort of medico-legal aspects of this. And I was just going to give you another case, not dissimilar in some ways, but perhaps a little bit more based in the real world. Is a middle-aged man who is a keen cyclist, is on his way to work when he hits a car. He is wearing a helmet and hits his head. He briefly blacks out for a period of seconds and has a Glasgow Coma Scale score of 15 out of 15 at the time, which is certainly one of the key things to look out for in any medico-legal report. The other thing that I hadn't mentioned there would be post-traumatic amnesia. We know that anything longer than an hour can have prognostic implications. So he attends the emergency department. He's off work, and he has a brain scan in the emergency department, which is normal, and he comes to see me or another medico-legal neurologist some 18 months later with poor function. He has quite a number of symptoms at this point, and it becomes clear that there's quite a bit of overlap between those symptoms that would normally be attributable to a mild traumatic brain injury versus that of a functional problem. I'm in receipt of the bundle, which not unusually is incomplete, out of order, with quite a number of pages upside down. But I managed to get through that, and what becomes clear is that he's had quite a difficult childhood. There have been periods when his mood has been low, he drinks a little bit too much, and his marriage is looking a bit shaky. Furthermore, there's some history of some psychiatric problems with antidepressants in the past, and a careful look through his records soon reveals that there's some inconsistencies between the primary and secondary care record, and indeed his own statements and those from witnesses. The case is quite protracted, and finally, when the two experts get together, they are in fact, thankfully, and I'm wondering if perhaps a little unusually, fairly agreed on all the points that have been raised, and the case gets settled, thankfully, some 10 days before the court hearing. So inevitably, I think we need to think about how consistent this person is. And I think it's important that medico-legal neurologists, those who compile reports, do look at that. We pay careful attention to the activities of daily living. And I think it's important to bear in mind that, of course, our activities of daily living, or ADLs, do vary from day to day. And indeed, it is also important to know that all of us, be they solicitors, be they neurologists, be they those who are running medico-legal chambers, do have bad days. So important to bear in mind that we are human. And it can be very difficult to work out what is going on here in terms of what's voluntary, what's involuntary, and which symptoms belong in which categories. And I think it's fair to say that sometimes that's actually impossible. Despite that, I think it's important that doctors, medico-legal doctors, and solicitors do try and talk the same language. And this is an area that does interest me as to how we can do that. It's a little bit like somebody from the south of England doing their exams, medical exams up in Glasgow. Difficult to understand. And of course, we do recognise the differences in medical and legal definitions. But when it comes to causation of FND, broadly speaking, there isn't a single cause. We do recognise a number of factors that I term as the 3 Ps: the predisposing factors, the provoking factors, and the perpetuating factors. I'm going to come back to those in a minute. DSM is, of course, the so-called classification Bible when it comes to psychiatric disorders, but I don't necessarily think of this as a psychiatric disorder. Indeed, I think it lines up much more with a neuropsychological disorder. That's a personal opinion. I'm sure there'll be those out there who disagree with that. I don't find this definition particularly helpful. Any definition that says we don't have a better explanation or it's incompatible with anything else doesn't offer, in my opinion, a great deal of assistance. Oh, sorry, yes. Going to say a little bit about mental health. I work closely with psychiatric colleagues in this area. Indeed, I think probably the one time when patients are, no, not the one time, but one of the times when patients are not really suitable for psychological intervention is when there are a lot of mental health problems on the cards. And indeed, sometimes we need to wait while people try and get better from their bipolar disorder or their very significant depression or their bereavement reaction or something like that. So lots of patience is required. And I think it's important that psychiatrists are involved in those kind of discussions. And as I say, in Exeter, we run an MDT model. I'll touch on that in a moment. I think my psychological colleagues probably are the most pivotal to running this service. In terms of what interventions they offer, they come in a number of shapes and sizes, but just to pick out a couple, so we do use cognitive behavioral therapy. That can come in different forms, and of course, post-traumatic stress disorder, PTSD, is actually quite common. Just to give you an example of a patient I've seen recently, which was quite topical actually, because he was rescued from one of the prisons outside Damascus, where he'd been imprisoned underground, and he was aware that those in cells next to him were routinely pulled out and shot. Difficult really to kind of get your head around the level of psychological trauma that involves. This is our model in Exeter. So this is just how we try and divvy up a limited resource. Those with non-epileptic attacks, also known as functional seizures, tend to go in the direction of my psychology colleagues. Those with movement disorders or loss of movement disorders tend to head in the direction of my physiotherapy colleagues. Functioning generally, or communication and swallow, are taken on by our speech and language colleagues, and occasionally also input from occupational therapists. So I kind of float around, if you like, kind of trying to interdigitate with that. Brief slide on some theories to account for functional neurological disorders. Increasingly, the literature is now looking at the role of prediction that the brain has in terms of an expectation that may or may not be physically present, often more not than present. And there's a role for vigilance. Some of you may be aware of some of the events going on, particularly during COVID, when there was an outbreak of functional tics. And so the role of suggestibility also comes into that. But first and foremost, we think it's a network disorder, similar to epilepsy as such. So if you can imagine, you've got a football field full of people, and you've got a goalkeeper at one end and a goalkeeper at the other, and you want to get a clear message from one goalkeeper to the other. What are the chances of them receiving a clear message from the other end, having been passed through all of those people? That's the way, in a sort of rather crude, rudimentary sense, I think of as a network disorder. There are quite a number of pitfalls, particularly in terms of medical practice, but one or two, I think, in terms of medico-legal practice as well. Broadly speaking, they fall into two groups, namely that of over-reliance on certain things, for example, normal investigations, and under-reliance on things like history. I was reminding my trainee of the importance of taking the history only recently, and sometimes even I need to go back and take the history again, because perhaps I didn't do as good a job of it as I would have liked first time round. There are other possibilities to things that look functional. We do recognize a malingering or factitious disorder. This represents a small proportion of those who we think may have functional problems, and almost always involve some form of secondary gain. And I think it's important to recognize that even neurologists sometimes get this wrong. I thought I would touch briefly on a couple of common medico-legal scenarios, specifically that of mild traumatic brain injury. There remains quite a bit of debate as to whether this is a functional problem versus an organic problem. And you will be able to find neurologists out there who fall clearly into one camp or the other. I think maybe things do start off organically, but I think with little doubt there are clear functional components to the post-concussion syndrome. I personally like to use something called the Addenbrooke's Cognitive Examination, or ACE for short. It's a really good cognitive test. It covers multiple domains and is validated for what we do. So I do that on, in fact, I do that on all folk with head injuries. Dizziness is very common. It means many, many different things to different people. I think there were 30 different meanings last time I looked at the Oxford Dictionary, probably more by now. But broadly speaking, we try and categorize that. That can be difficult because there can be bits of both. Increasingly now, we do recognize a syndrome of persistent postural dizziness, particularly prominent in middle-aged or later-aged women. And and that's thought now to sort of broadly speaking fall within the functional domain. There are some clues to a functional problem which I've listed here. I'll just give you a moment to have a little look through that list. Whilst we do that, I think it's important just to highlight one particular area, which is of course really quite new, namely that of long COVID. I'm yet to be convinced that long COVID is a functional problem. There are all sorts of bits of research coming out now suggesting that this virus is extremely good at evading our immune systems and causing persistent symptoms, and hence I'm open-minded about that. Undoubtedly, there are bits that would fit the functional disorder, but I'm hesitant to ascribe it in whole to that. We do need to talk about causation, and that is a difficult thing to pin down in FND. So I don't think it has a singular cause. And we do recognize these factors, and I'll just talk you through some of them. Trauma is common. It can take either physical or emotional guises. And I think the point really to take home from this slide is particularly that what is traumatic for some may not be traumatic for others. We do recognize increasingly that people with FND have personality disorders. I'd be interested to know from the solicitors amongst you some of the sort of legal aspects of that, but in the past it was thought that personality disorders couldn't be treated. I think increasingly evidence suggests that actually things can be done and that we need to try and be a little bit more optimistic. But certainly early life stuff is very important in terms of predisposing factors. Often it's a physical event that provokes it, sometimes very trivial, but it sets in play a sort of psychological array of events that follow on. Vaccination, I think, has become increasingly common again, I think, in the context of COVID. But in truth, any adverse event can do it, and not necessarily the adverse event that you might think is adverse. You know, for example, your kettle going wrong or your cat being sick on the carpet, for example. Apologies for this, but like it or not, litigation is a perpetuating factor, and I think it's all important to try and conclude that at the earliest opportunity. Many cases are long, protracted, lasting years sometimes, but getting closure on this with respect to that is helpful. Getting closure on the diagnosis is helpful. Getting some sort of closure on some of the mental health aspects is helpful. And of course, some of these things, you know, might not necessarily be either in the patient's control or, frankly, under the control of any of the rest of us. Prognosis is difficult, and in terms of what dictates that, I think it is dictated by a few things. First and foremost is those who do best, a bit like long COVID actually, are those who are most accepting of the diagnosis. Some are fiercely resistant. They deem it to be highly stigmatizing and will not entertain any discussion of that. Indeed, I've seen patients who said, you know, if you use the word, the F word, I'm leaving by that door over there, Dr. Price, and this conversation is over. So that's pretty challenging. And then I think the other thing that can dictate prognosis is the duration of symptoms. If they're very entrenched over a period of years or 5 years, 10 years, then it's relatively unlikely you're going to have much impact on that. They will have already developed whatever bespoke coping strategy they have by that stage more often than not. But there may be still things you can do to help. So thank you very much for that. I'm just going to put up my last slide, which is just a few pointers in terms of where to go for information, where to go for support. And these people, do offer support. And I think it's fair to say that they also signpost for patients in terms of trying to get more specific treatments. Say, for example, veterans who have FND relating to post-traumatic stress, for example. So thank you very much for your time. I'm really happy to take a few questions if there are any.
Thank you, Dr. Price. There actually are a few questions that have popped up on the system. So if I may, I will start with them. First of all, from a Natasha, who has asked if you could please explain the differences between FND and fibromyalgia and whether they are misdiagnosed.
Yeah, so fibromyalgia is a chronic pain state, and it's not a well understood. We think it's a wind-up mechanism within your pain pathway, but and I've had a reasonably recent look at the scientific literature in this regard. The real hard neuroscientific evidence for that is a little bit thin on the ground. So, for example, without getting too technical, the pain fibers within your peripheral nervous system convey matters to the spinal cord, and within a particular part of your spinal cord, there is a chemical called substance P that is thought to be in a state of is present and amplifying, a bit like your hi-fi at home, amplifying the pain signal. What happens as it gets passed up the spinal cord to all the higher processing bits of your brain is, I think, probably beyond, it's not something I can answer in this seminar today, but I think broadly speaking, I am thinking of FND as an umbrella term. So, and under that umbrella falls fibromyalgia, falls other things like non-genetically defined Ehlers-Danlos loss, postural orthostatic tachycardia syndrome. Sorry, I know that sounds like a bit of a mouthful. And other things, other specialties like irritable bowel. So my view, and there are those who are lumpers and there are those who are splitters. I fall into the lumper category. I think of it as a sort of broadly speaking as an umbrella term.
Thank you for that. Second question from Dan. How frequently are people initially diagnosed with FND before they get a more precise or accepted psychiatric and/or physical diagnosis?
I think it depends really who you see. Many doctors, and I include general practitioners, and even some neurologists are reluctant to diagnose FND because they're worried about getting it wrong. In fact, most neurologists don't, but all do at some point. And so they will often defer to us for that. And, I see people for second opinions, even for, very experienced neurologists who are not sure. And I do make referrals on to more specialist colleagues, for example, at the National Hospital in Neurology in London, where I think I'm not sure if it's an organic problem or a functional problem. I've usually got a pretty good idea. But my experience is that actually psychiatric disorders tend to come later or are present when I see them. So, for example, as a consequence, a patient might say, of all this uncertainty, all this diagnostic doubt, understandably, that's made them quite depressed. In my experience, that's a slightly more common scenario. But of course, they can come in any order. There's no textbook that people adhere to. I guess otherwise I'd be out of a job.
Thank you. There's actually 2 or 3 more questions. So Vanessa has asked, what considerations should be taken into account when assessing long-term care and costs for individuals with FND in medico-legal matters, medico-legal claims?
Yes, that's a great question. So to come back to the sort of prognostic bit that we spoke about, those who have a long duration of symptoms, those who are not accepting of the diagnosis, I think I don't want to kind of generalize, but a sort of broad brush explanation would be that they tend to have the greatest burden of disability. But also they've developed their own coping strategies. So they have a high degree of long-term care requirements. For those who we see earlier, actually, we've got an intervention opportunity, and I see it as my job to get people with functional neurological disorders who I see in wheelchairs. I tell them straight, I give it to them straight. I say, my job is to get you out of that. And my job is to prevent you requiring long-term care. So, you know, you've got a guide here. There isn't a sort of precise protocol for such things, but you've got a few things that will help guide you. And I've seen some functional patients turn it round, you know, pretty, I won't say miraculously, but I have seen people walk again who haven't been at walking for several years. And I can't tell you how gratifying that is. You know, it's one of those things that really keeps doctors going. It really helps with the, you know, compassion fatigue in what is an under-resourced, overstressed service.
Thank you for that. The last two questions here are a little bit more client specific. So maybe a short answer is better now, and obviously you can look into it more if they want to send you some more detail in the future. But first of all, from Debbie, she has a client who's diagnosed with FND after a traumatic brain injury. He's had episodes where if he gets stressed, he can't mobilize, he can't talk properly or understand more than a few words at a time. He is 10 years after the core brain injury. Could these symptoms be FND? And is it possible he always had them? He was told FND was a one-off issue and gets very little understanding from the NHS.
Yeah, thanks, Debbie. Great question. So without going into too much detail about your case, I'm getting quite distinct flavors of an FND problem here. This has been going on for 10 years. I mean, I don't want to contradict myself, but having just said the longer it goes on, the less good the prognosis. That's a pattern. But I think it really important not to be, you know, therapeutically nihilistic about this. He probably was told that FND was a one-off. I think FND is much more complex than that, you know, without kind of going into the sort of digging around and into people's past, which is often very, very difficult, particularly if it involves sexual abuse. You know, I think these things do need to be explored by those who probably are frankly better at it than myself. You know, we tend to try and ask open questions in neurology. So, you know, I don't come out, oh, have you been sexually abused? But can you tell me, you know, a little bit about your childhood, for example? Yes, it could certainly be FND. No, I don't think this should be written off in terms of treatment and recovery. And I'm always trying to kind of keep an upbeat kind of message going for patients that, you know, there remains scope for recovery throughout. It gets less probable as time goes by, but always trying to be hopeful.
Brilliant, thank you. And just lastly, from Shireen, her client has recently been diagnosed with a non-epileptic attack disorder. He was diagnosed with concussion after an accident 3 years ago. Scans have shown no damage to the brain. What is the likely treatment pathway, assuming the diagnosis is correct? And is prognosis with treatment generally positive? Again, this is quite specific this case,
Yeah.
but perhaps a broader answer, and then obviously Shireen is more than welcome to send some more detailed information across.
Sure, no problem. Again, a very good question, Cherie. So non-epileptic attack disorder is common. To just give you an example, if you have a robust and sound diagnosis of epilepsy, the chances of you developing non-epileptic attack disorder or functional seizure disorder, you carry a relative risk of about 6 to 8 that of a background population. So, it is, and often the two can coexist, and it is quite a substantial part of my professional life spent trying to work out what's what. So our treatment model in Exeter, which I think works, it doesn't work for everybody. Sometimes you don't know if it's going to work until you do it, is based on psychology. They tend to offer a number of sessions across time, but that's changed a little bit because our resources changed. So now generally what we would do is, because we have an online psychoeducation program, we tend to try and point patients in that direction. That happens over a 3-month period. That's a sort of gradual getting to know you and your diagnosis kind of process. And then, if that's making sense to the patient, then and they're signed up and feeling supported, but wanting to take things further, they tend to go on for a more formative psychological assessment. I think psychology for non-epileptic attack disorder is the mainstay. Obviously, neurologists are involved in the diagnosis. Along the way, so just to come back to the epilepsy example, for example, some 30 to 40% of patients with epilepsy, 50% if you have Parkinson's disease, become depressed at some point. Again, reflecting the network disorder nature of what we're dealing with. So to reiterate an earlier point, certainly a functional flavour, options for treatment as outlined, and always trying to keep, to stay optimistic.
Well, I think that brings all the questions to an end. Thank you very much, Dr. Price, for your time today. Really is wonderful to hear you talk about this topic, and I think I speak on behalf of everyone to say that this was incredibly insightful, and we appreciate your time.
Well, I hope it's helpful and informative. Thanks.
Brilliant. Thank you.